Neha, we want to say a few words? Yeah.
Yeah. Good evening, all of you. My name is Neha Pandit from the Emcure Pharmaceuticals. We feel privileged to be a part of this webinar of the Obstetric and Gynecological Society of Southern India on the topic of medical legal issues in obstetric and gynecological practices. And also, I'm honored to introduce Dr. KSJRNE Kamraj, President of the OGSSI, and Dr. KM Kunti, Ma'am, Honorable Secretary of OGSSI. So, welcome, Dr. KSJRNE, Ma'am. Doctor. Yes, ma'am.
No, it's okay. That introduction we can skip off. Not a problem. I'll start my welcome address.
Yeah.
So, thank you, Neha. It has been a great pleasure and honor. So, can you hear me, is Neha?
Yes, ma'am. Yes.
Yeah. So, it has been a great pleasure and honor to welcome the chief guest, Dr. Narendra Malhotra, sir, guest of honor, Dr. Patil, sir, and the elite speakers, Dr. Hitesh, Dr. Nitish, and Dr. Manish Machave, and sir, and the chairpersons, Dr. Komal, Madam Sahay, and Dr. Rajesh Bhatt, and all the senior faculties of this webinar, and my dear Foxians as well as Oxians who have logged in to be the part of this wonderful webinar. It has given me great pleasure and honor to welcome our chief guest and the guest of honor who has accepted in midst of their busy schedule to give a few words for this medical legal, difficulties, what we come across in the medical legal practice in our routine gynec practice. So we all know, though we are very busy with the practice, we have a lot of legal issues that we come across in our routine practice. And as an ART specialist, we still come across a lot in this upcoming ART law. So we have a lot of doubts and questions and difficulties as and when about the concern, about the difficulties when we come across a difficult case or a sudden unexpected trouble when we face in the routine practice. We need to have a lot of legal issues which is back in our mind. For this one, we have, as an Obstetric Gynec Society of South India, we plan to have a webinar where we have all the senior faculties here. Their expertise, knowledge, and their academic excellence in this topic to clear all our doubts, all our difficulties, which will be very useful for all the practitioners, especially the OBGYNs. And we have a very important vision in our OGSS society. We have started a medical legal committee, which is headed by Dr. Vijayalakshmi Sheshadri and Dr. Vivek Madi, who will be looking into all the medical legal issues, who are formulating all these issues and planning to have a helpline for Roxy, as Sir MC Patil sir and Geetendra sir has already formed for Foxy. We wanted to have one more in our society so that any difficulties for our routine people all over Tamil Nadu can get their opinion and guidance whenever they need it. So this is our vision, and to make this still more very clear and good knowledge about all the difficulties, we have this webinar. I thank all the senior faculties here and our chief guest, and I welcome you one and all, and a special thanks to Emcure Pharma for giving us a platform. And over to you, Kundavai, for your Oxy prayer. Kindly share the Oxy prayer, Neha.
Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Nothing is possible without God's vision in the form of light to shower us with the knowledge of light. We start this webinar with the lightning of the Kuttuvilakku. So audio is not heard. Neha?
Yes, ma'am.
Audio, we could not hear the Tamil Thai word. You can just go for the inauguration with the Kutvalak lightning, at least you can have.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் மதனமென திகழ்வரத கண்டமிதில் திக்கணமும் அதில் சிறந்த திராவிடனும் திருநாடும் தக்க சிறு திரை முதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறந்தியந்து செய்ய மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Neha.
A chief guest, Neha, it's the Sir Narendra Malhotra, sir. No. So it gives me a great pleasure, honor, and pride, and so much heartful of happiness to welcome our chief guest, Dr. Narendra Malhotra, sir, who is a very dynamic and very knowledgeable and a very senior person in ART with a lot of knowledge about various things. A man of, I would like to say, he's like a walking encyclopedia. He talks about obstetrics, gynec, fertility, ART, stem cell, and aging, graceful aging, and anti-aging. Everything is Sir's. Everything is about Sir means he's like a walking encyclopedia. That's what I always feel when I see Sir. Sir is the president, was the president Foxy in 2018, and he's the dean of ICMU, and he's a national technical advisor, Foxy IOG, and the MacArthur Foundation of EOC course. And Sir has a very special interest in almost everything in OBGYN, and he has published many international and national publications, and he has given a lot of national and international guest lectures, and he has been a trainer for most of the ART specialists. And it is a great pleasure to have you, Sir, for our webinar to preside and give your chief guest address, sir. Thank you for joining us, sir, and it will be a great pleasure for us to hear from you, sir. Over to you, sir.
A very good evening to all of you. It's indeed a pleasure to be here in this webinar. I mean, can I say that this is the theme of today, medical legal. We all practice OBGYN, infertility, everything. And we were doing it, a lot of us were doing it however you wanted it. But since we had consumer forum, since we had medical laws, and now a law for medical, every specialty coming in every day, we need to be very, very medical legally literate. And that is very important. We just can't get away by saying that we didn't know the law. I'm sorry that I did not know the law and all. This new latest ART law is what is upsetting a lot of us. But I think we needed a law. We needed an ART law, except for a few clauses which we are not agreeable with the government, and which we did try in the parliament, and a lot of them are trying in the Supreme Court also. And but it was good that we have on the board experts from our own fraternity, Dr. Patel, Nitin Murdia, all these are experts. They are our own people there, and they will be able to represent us and help us in case there is any problem. But let me tell you, all gynecologists who want to practice infertility, you will have to get yourself registered as level 1 clinic, level 2 clinic, and IVF, ART clinic, surrogacy clinic, or a bank. So you need to know these. And today we have, I see the experts as MC Patel, Hitesh Bhatt, Manish, and Nitij Murdia, who will be taking us through the expert points of this law and the other laws which are there. And a lovely panel of experts and all women experts, speakers who will be talking to us about these laws. So let's go ahead, listen to all of you, and come out with a clear-cut guidelines on how we should be medico-legally literate, and how we should be on the safe side and yet give the best to our patient. The patient should not suffer by defensive medicine. So that defensive medicine, refer it, I will not do high risk, I will not do this. That who will do then? Who will save lives if we don't do? So, but then we should not be scared of the laws also. You follow the law, do your work, and you'll be safe. Thank you very much, Jayarani, for inviting me to this webinar, and all the best to you for the future in Foxy also, and to all who are there in this webinar. Thank you very much.
Thank you, sir. Thank you for your lovely words and inspirational words. And it's a real thought-provoking for us to look into all the medical legal issues to get ourselves well updated so that it is comfortable for us to practice safely also. So thank you, sir. Thank you for joining with us. And I have the great pleasure and honor to introduce Dr. MC Patel, sir, the guest of honor of this webinar. Sir is the past Vice President of Foxy. He is the honorary member of the PNDT Act. And sir is well known for his, elaborate knowledge about the medical legal aspects, and all his consent forms, universal consent for our OBGYN practice, and his emergency in-call online things, whatever he has done for Foxy, it is really amazing. And I really very much admire you, sir, for all your work you have done for the medical legal issues of the practitioners. And your continuing masterclass of all your classes are really thought-provoking and very much, updating us with all the obstetric and gynec knowledge. And so many, you have done a marathon sessions of so many sessions, and has been very much useful for most of the gynecologists all over India. And I really thank you, sir, for that wonderful classes series of yours. And you have joined us in between your class, and that is a great pleasure for us, for giving us this nice time of yours, sir. And the sir is the organizing secretary of ACOG 2017, and he's the chairperson of the Ethics and Medical Legal Committee of Foxy in 2011 and 13. And he's a very important medical legal counselor and honorary joint secretary of the State Organization of the Gynecologists and Obstetricians of Gujarat between 2019 and 22. He's the organizing chairperson of conference in 2018. And he's the organizing persons of so many conferences and so many organizations. And he has done a lot of work in the Red Cross also. He's actually actively participating in the Red Cross by doing the honorary surgeon, collecting more than 1,000 iPads, which is really amazing. A wonderful thing that I could see in your CV, sir. And it is really thought-provoking and kindling our interest, and also making us to do something really for the society. Whatever you're doing is really great, sir. And we are very happy and thankful to have you, sir. Over to you, sir, for your kind words.
Thank you, Dr. Jayarani, for kind words. It gives me immense pleasure to be associated with this very important webinar on medical legal, very rightly said by Dr. Narendra Malhotra, sir. Also, in this era of CPA, ignorance of law cannot be an excuse. Because in India, whenever any act, any law, any ordinance passes in government gazette, it is presumed by law that each and every citizen of India knows that law. So ignorance of law can never be an excuse. And we should be well aware of all the laws and acts which are prevailing in our day-to-day practice, and almost more than 153 laws which are applicable in our obstetric and gynec practice. But we should be well aware with very important acts and laws, and then only we can save ourselves from medical legal issues. But the very important thing, because it has been our experience during our medical legal practice, medical legal litigations are increasing in number constantly and steadily. And we gynecologists, unluckily, rank first as far as medical legal consequences are concerned. So we should be very careful, because we are looking with two life, mother and baby. And so we are at vulnerable position as far as medical legal parts are concerned. So we should to get rid of it is a very important thing. And as far as law is concerned, the 2-3 things we have to keep in mind. Even law also expects from us. And one is anticipation or foreseeability. Whenever we are dealing with any case, then we should anticipate which could be the complication in this management. So we should be well prepared to deal with the situation accordingly, if at all it happens. And at the same time, proper counseling and proper consent. And consent is not mere piece of paper. It was very nicely mentioned in one of the case, that is C. Jaipal Reddy versus Padmini Velluri, that it is not mere piece of paper where patient or relative has to sign, but it is a very important document of your counseling. Whatever you have counseled to the patient, it should be well recorded in that consent paper, and then patient and patient party has to sign. Then it becomes a good document in your favor whenever you have to face any litigation. And after counseling and consent, proper record keeping, that is documentation, is very much important part. So it shows your consent, whatever you have done for patient as far as management part is concerned. And if you are well documented, it shows your consent to save life of patient, and it becomes a good defense in your favor. And it is very obvious in my lecture also, I usually mention that good record is always good defense, poor record is always poor defense, and no record is no defense. And it is experienced during our medical legal practice. We doctors' friends are very poor as far as record keeping is concerned. And many a times it becomes very difficult for us also to defend our Foxian friends in this type of situation. So again, congratulations to Dr. Jaya Rani and Kundavi Devi for keeping this discussion, medical legal issues in OBGYN practice. And thank you for inviting me to share my views about the subject, and inviting me to be guest of honor, to be part of this very important webinar. Thank you very much. As such, I am busy with one parallel session of Happy Learning Masterclass. It is every Tuesday, but I cannot say no to Dr. Jaya. So I am here. I will be logging out for a while. I will have my lecture there. And again, I will rejoin this webinar to have my expert comments during panel discussion. So thank you very much.
Thank you, sir. Thank you for the nice and loving words. And it is really a pleasure to have you, sir. You are the person who is very dynamically doing a lot of work on this. In that part of our OBGYN practice. Thank you for joining us. And it is a real pleasure and pride for us to have you with us, sir. Thank you so much, sir. Thank you. Thank you, sir. Over to the
Thank you, sir. And Neha, can I have Komal's CV, please? We're just starting the sessions now. And it's my privilege and my pleasure to introduce the chairpersons, Dr. Komal Chavan. Her CV, please.
Yes.
Next slide, yeah. She's a medical director, Chavan Maternity Nursing Home, and a senior consultant and a DNB teacher of Desai Hospital, Mumbai, and a chairperson, Foxy Medical Disorders Committee 2019-22, and chairperson, AMOX for Family Welfare and MTP Committee 2022-2024, and national expert for Foxy UNICEF Lakshya Project, scientific secretary, AFG, and joint secretary, ISOPAP Mumbai chapter, She has won lots of prizes and awards. Can I have the next slide of Dr. Rajesh?
Yes, ma'am.
It's my pleasure to invite Dr. Rajesh Bhakta to chair the session. And he's a specialist in IVF also, and he's just got a Foxy Contact Device Award for young doctors. And he's published a lot of papers, pain management in endometriosis, and won the Jawari Prize for Best Paper entitled Silent Bacterial Infection. So over to you, Dr. Rajesh and Dr. Komal, to take over the session to introduce Dr. Nithis and Dr. Hitesh Bhatt. And we will start our questions then.
Thank you very much. It is my great pleasure. First of all, let me take this opportunity to thank the OGSSI for giving us this opportunity. So I would like to introduce our first moderator for this session, Dr. K.S. Jairani Kamraj. I think, looking at her CV, I think the beauty and the brains have come really together. She's been extremely good in during her university exams, both in MBBS as well as in the postgraduate, getting her gold medalist. She also awarded many best doctor in MGR University. She has been part of the organizing committee of various like ISAR, and also she is many life member in many of the organizations. I present to you Dr. K.S. Jairani Kamraj, who is presently the president of OGSSI. Welcome, madam. I also like to introduce the second chairperson, Dr. K.M. Kundavi Shankar. She is also the honorary secretary of the present OGSSI. And she is a renowned national board certified OBGYN, and also specialist in both reproductive medicine and laparoscopic surgery, and vast experience of more than 20 years. And she's trained in ultrasound and andrology. She's a lead fertility consultant at IRM and MMM, an active member of Foxy and many other societies like ISAR, IMA, and other things. She's also a member of many of the Foxy committees like Endometriosis Committee, and also has fellowship program in IRM and MMM. I present to you Dr. Kundavi Shankar, who is presently the HOD and senior consultant, and also secretary of OGSSI. Welcome, ma'am.
Thank you, sir. Thank you, sir. Can I have Dr. Nithis CV and Hitesh CV, please? We have Dr. Hitesh Bhatt. Can I have the CV, please? He's got, who knows, no introduction to this group, and he's a medical legal consultant. Started as an OGician, but I think now is an advocate, focusing at Andheri, Mumbai, medical legal consultant since the last 20 years. I think he is a savior for all the gynecologists. Delivered a lot of lectures. Next slide to Dr. Nithis. It's my pleasure to introduce Dr. Nithis, who is an expert member, National Assisted Reproduction and Surrogacy Board. And among many awards, he's won one of the prestigious, the budding embryologist of the National Gold Medal Award, and the leading team of 160 embryologists. I think big hats off to him for an educational program of national international candidates. I think it's a special interest in AI and brought an exceptional technological advancement in Indra IVF. So without wasting much of our time, we are going to start the medical legal practice in fertility. Dr. Nithis, is it compulsory for the donor to be married, but there was nowhere it's mentioned in the bill? Or is it mandatory to collect the marriage certificate if so? Dr. Nithis?
Yeah, so as per the Act, the donor, there is only age criteria, which is that the donor has to be between a certain age. The Act does not say anything about married or non-married. The Act does not say about known or unknown or relative. So we just have to comply with the age criteria. It can be a married donor or unmarried relative, known, unknown. All this category is possible. What was the second question about the marriage certificate of the donor?
If married, should we collect the marriage certificate or the affidavit is enough?
So Act does not specify that the donor has to be married. So there is nothing that we have to collect from the donor. We just have to make sure that the donor is in the age category which is specified in the Act.
So I just want to ask you one question. The Act has very clearly mentioned the donor should be an altruistic donor. So if it is an altruistic donor, how many will be willing to come and donate the eggs, sir? Is it really possible, sir? So to get because the law says that way. Now we are in a very, critical way that if the patient comes and asks, can I bring my relative donor to donate? Is it allowed, sir? Because pastly it is not allowed. But now will it be allowed to have a relative donor to donate her the eggs? What is its legality and how we look upon it?
Yeah. So the Act came into place because the government wanted to decommercialize everything, be it surrogate or be it donors. They wanted to stop this commercialization of the practice and exploitation of the donor and the surrogates, which was happening in the past. And that is why this law came into play. In terms of the two regulations that have come, which is first thing that the donor has to donate only once in the lifetime, and it has to be one donor, one recipient, has kind of decreased the supply of donors ecosystem. But what relaxation has been given is to increase is first thing, a known donor is allowed, a relative is allowed. And second, there is no restriction in terms of the marriage or married donor versus unmarried donor. So both these two aspects are removed, which used to be there previously. Anonymity and married donor is removed to increase, and the other two things will decrease. So that is what the whole thought process of the government is, to stop the commercialization of the donor and the surrogates, and that is why this law has been come into place.
I would like to give you the legal insight why it has happened. See, previously there was no law. Now, if somebody can prove that I am having the genetic linkage with this person, then automatically that person becomes either father or son of that particular donor in absence of the law. Yeah, if you remember that Tiwari, PA, from the Congress, he was implicated for having a child, illegitimate child, because he proved that he is having the gene of Mr. Tiwari. So that was because there was no law. Now in the law of ART, it is very clearly mentioned that once the genetic material is given for a donation, the person, the donor, will have no right on the child, and child will have no right on the person who has given the donation. So that clarity makes it very obvious. Now in adoption law also, we know that who is the father and who is the mother. It is a live born child which is given for adoption. Still, once it is given for adoption, adoption law says once child is given for adoption, he will have no linkage with the previous parents. So same thing has come now. So that is why there is no need for anonymity now. It is at the discretion of the donor. If she wants to remain anonymous, then she can be. Otherwise, there is no need.
Sir, have they considered the psychology of the child born, sir? So because the child born will have a psychologically, when it is open, that it is a relative or
yes, it is that the couple will have to think. And second thing, child psychology was decided even before this when they passed adoption law. Adoption is ready-madely born
okay,
child. It is already a born child, and adoption is possible up to 15 years of age. So that child already knows these parents for many years, while embryo doesn't know who is the parent. So it is rather more forward, and it is more safer than adoption, and still adoption is happening. So there is the legal catch was that why anonymity was required before and why it is not required now, because of this clause in the law. That is first thing. And second thing, you asked about the commercialization. Now, liver, kidney, all these transplants are happening. That is life-saving, and still it is non-commercialized. It is international concern that you cannot trade in any human or animal organs. So it is international concern, and no country will allow trade in any human organ for anything.
Sir, if they're the child, see, if it is a relative donor who the identity is well known. So is there any other way that the concern should be included, that they should not disclose, they should not have anything special we have to add if it is a relative known donor?
It is mentioned in the law, privacy of each patient has to be maintained, couples as well as donors. Now it is at the donor's discretion. If she wants to remain anonymous, then it will not be disclosed. But when couple themselves bring, there is nothing like anonymity, they know it. Now, whether they want to give this information to the child or not, it is up to them. And child has a right to know how he was born or she was born when she becomes mature. Not the name of the donor, but at least child will know that I am not the biological child of this couple. That is right of a child when child becomes major.
We know that the age is given as 21 and 23 for the donors. Recently, we had 23, a patient, 23 for the donor, and for the other couple is 21, right?
For couple, it is 21.
Yeah. 19-year-old Muslim couple who had come to us, married for about 1.5 years, and they've just come for the treatment. Am I justified in treating her, or should I say no to the treatment?
You have to wait till she becomes 21.
But how did they agree to get her married at the age of 18? You know, all the seniors would have, even in the mosque, they would have agreed, right, at the age of 18. When they have accepted at the age of 18, why not the baby at 19 and a half?
Because law prevents that. See, marriage at 18 is not illegal marriage. It is irregular marriage. While IVF at 18 is illegal IVF. It is not irregular IVF. There is a punishment behind it. And if you do it twice, punishment is 3 to 8 years of imprisonment. So whether you want to take that risk, that is up to you.
We have to say, even at the registration desk itself, we have to say no to the...
You can investigate. IVF you can't do. You can investigate. You can start doing cycles. You can just check whether she is ovulating or not. You can see natural cycles. You can also give time intercourse. You can suggest. You can get investigations done. If a hysteroscopy, laparoscopy is required, investigations you can do. All these things you can do. Only thing is you can't treat them for ART.
Sir, if they are in a form of a POI or a premature insufficiency with an AMH high and they have a very poor reserve coming at 19, there are some patients still coming with this a low reserve, even at 19. And they are very much aware of the fact that my antral follicular count is less, my AMH is less, and somebody would have, the referring family physician would have told that your reserve is very less, better have yourself treated fast. Am I justifiable in doing for a 19-year-old or a 20-year-old when they have a poor reserve to take them for an IVF?
Not for IVF.
When there is an indication, when there is an indication or an exemption that we can make up in the...
It is not there in the law. No such exemption is given. You can freeze the oocyte at the most if you want to do that. That you can do even for a minor. But you cannot make embryo and you cannot transfer the embryo because law doesn't give any exception. There is one dictum in the law. The correctness of your action doesn't make it a legal action. Suppose some girl is some couple is having 5 females. I am not justified in doing sex determination for the 6th one. I know that she will keep on continuing with the pregnancies if till the time she is getting male child. She will have more load. She will have 10 children. She will have 50 children. That is not my concern. Law says you can't do means you can't do. That's it. So law always says you
we can stimulate, we can freeze the embryos. Only thing we cannot transfer.
You cannot make embryos also.
Oh.
Right.
The Kerala government has given a verdict, right? Like 45 years woman and 56 a year of the husband. We have the embryos frozen 4 years back and 1 cycle has failed. And they started the treatment when the husband was around 52. With the Kerala government verdict which has been given, can I go ahead with an FET of this couple?
Kerala verdict is always given for the one who has pleaded in the court. It is not law. It is applicable to that person. If some court has given divorce in a similar case, I cannot consider that as mine and I give my divorce to my wife. I have to plead again. This case will work as a precedence, but you cannot directly take it as a general rule.
If we have frozen the embryos 4 years back when he was only 52, should we really ask them to go to the court again?
No, it has, sir, it has been given, it has been given before August 22. If they have been frozen, we can transfer. The age limit was not there. Am I right? So this is
After the law, you have to follow each and every section of the law after 25th of December 2021, when the law came, and from January it came into existence, 26 January 2022. From that, the law is enforceable. So you have to do everything which is written in the law. Whatever is done in the past becomes null and void.
So patients who have been registered with us at the age of 51 before, in 2021, and now they are coming for treatment.
You have to stop.
Justified?
You have to stop. When law says no, that you can't do, that's it. Understand that thing. And the punishment is 3 to 8 years of imprisonment. You can treat it if you don't fear jail. That's it.
So we can ask them to go to the court and get the directions,
Yes,
and then
they can go to the court, they can get the judgment, and they can come back to you if the judgment is in their favor.
So that's what we want to have, a very clear idea that whoever who comes with it, they can go to the court, get the directions, and then we can start the treatment, right?
Yes.
What about the central registry for sending the data?
You mean to say the national registry?
Yeah.
Yeah, so I think it will take some time. It's getting formed, but meanwhile, I think state has already rolled in some format where you have to. I think I have seen Tamil Nadu state government which has formed a Excel kind of sheet where you will have to submit the data at the end of the month.
Every month, every month we are doing. For the past 4 years, we have been doing. Am I right, Kudavi?
Yeah, but they're asking us to tell us the monthly income as well. Is it necessary to send the monthly income of the unit, which we were never doing it all these years? That's one thing added there.
Ideally, this doesn't make sense, but I don't know. State authorities can ask any information, but it was a discussion going on the group also. It's kind of very I don't know what to say, but that's what the state government can do.
Can we have a common way of reporting, Dr. Nithis, because each state may have different ones, but the same thing will have to go to the central registry also, right? Can we have a common format?
See, the thing is, even if you look at the PCPNDT law, I think within the state also, different cities have a different reporting. It was a part of the act which said that there has to be 7 follicles only retrieved. They did not do any modification in that because that's a long process. But they added an extra line saying that all follicle form has to be retrieved. Okay. Now the whole thought process of this 7 follicles in the donor came with a thought process that we should try to safeguard and protect the donor from overstimulation, from harsh stimulation, so that her health as well as the risk associated with OHSS and other things is avoided. Once the eggs are retrieved, we again check with the government that what to do with these eggs. And they were of the opinion that, see, once the eggs are out, there is nothing that you can do with the donor, because whatever risk has been caused is already caused to the donor. So whatever eggs are retrieved, you form the embryos and ovaries, but you have to use it only for the same couple. But it doesn't mean that we exploit this particular aspect of the law. We should make sure that we practice self-regulation, and we make sure that we mild stimulate the donors, because again, this act also tries to safeguard the risk associated with donation. That is the whole objective.
See, the thing is, rules cannot be over and above the
superseding the act.
Yes. So the law says 7 oocytes means 7 oocytes. You can take more, but you have to use 7. Even in that circular also, they have said only 7. They have not said you freeze rest of them for the couple. It is out of 7, you have to freeze rest of it for the couple.
I have to ask one question that you said use 7, but sometimes if the patient has a success, like can the patient donate the eggs? Like she used 2 or 3 and she has got pregnant. So
No.
the remaining ones, can they be donated, or if you
No.
have stimulated more than
No,
that?
No.
no.
The answer is no.
Sorry, but how long can we keep the freezing vitrification embryos? How long? For the cancer survivors, they say it's 10 years only. Now, sometimes the survivors it's more months.
It is for the period of 10 years, but especially for oncofertility patient, you can apply to the national board and it can be extended accordingly, but it has to be with the permission of the national.
They have said embryos and donor gametes cannot be stored beyond 10 years. So any embryo cannot be stored beyond 10 years, and donor oocytes or donor gametes, either sperm or oocytes, cannot be stored beyond 10 years. Self gametes can be stored beyond 10 years with the permission of national board. These are the exact words from the law.
Can a donor be stimulated in a different state and come back to another state?
Yes, there is no such law.
Okay. And can some analysis be done in any of the pathology labs, or pathologists can do it?
What?
Because
Semen analysis? Yes,
analysis.
analysis anybody can do.
Not in level 1 or level 2. The lab has to be registered, right, as a level 1 clinic.
No. See, what is ART procedure? You have to read the definition of ART procedure. That is the first definition given in the ART Act in section 2. It says ART procedure means to take the oocyte and sperms or gametes outside the human body and putting it back into the female genital tract. That is called ART. Now, as long as you are just assessing it and you have no intention to put it back into the genital tract, you are not doing ART procedures. And when you don't do ART procedures, you do not have to register yourself under ART.
So can we freeze the semen for the IVF for our own patients when we are doing
100%. You have to fill form 10. That's it. You can freeze the semen of the, not of the donor. If they are bringing donor, you have to route it through bank only.
Yeah.
The couple, if the husband is ready to give semen, he is not available, or you are keeping it as a backup sample, you can always do it with filling form 10.
So is there any other insurance, like any emergency, sudden some accidents can happen in our
For semen donor?
No. I'm not asking that. For the cryopreservation, we are keeping in a lab. Sometimes a fire accident or something happens in the lab, and sometimes the embryos happen to be an accident. Is there any other things that we have to do for about the insurance?
Yeah, I know of the insurances for the property, fixtures, furnitures, and the human body. But for the parts, human parts, if there is any insurance, I am not aware of.
Oh.
So nowadays, the insurance is not that easy. Like we said that we need to take an insurance for the donor program. But when we spoke to the insurance company, they said at least a year, they should have a year, 1 year for them to support the donor.
Today
It's a donor bank we're getting for 1 year, no, sir? 1 year.
You have to take insurance cover for 1 year. It should cover for 1 year. Insurance starts usually after 48 hours, 7 days, 3 months. There are various insurance. Some insurance like Tata, they are having one clause. If you pay some premium, it will start from next day. So there is the waiting period waive off clause. That clause is also there. But I'm not sure any of the insurance will cover a voluntary process of donation. That I'm not sure. Let any case happen. Let any case happen. Most of the time, the insurance companies are always intend how not to give money. They are not there to give you money. So they will find out some clause that this clause we will not be able to give you. Then case will be filed. Then Supreme Court judgment will come, and then it will be operational. Or they will come out of some policies that government promised that they will come out with some such policies which will be covering the donation part. That is first thing. And second thing, the insurance is always with the affidavit, because the law says if insurance is not there, couple can make affidavit that we will spend money if something happens to the donor. So we are asking at present both, because we are not sure about insurance. So we are asking couple to make affidavit also. So the interest of the donor is already taken care of by doing both these things.
Suppose we don't
So
have.
that, but you're not supposed to give for the medical expenses you can give, so that is in the law.
What medical expense?
Or the donor, if the donor, if though they may be in a altruistic donor, but when they have a OHSS or some problem following the say pickup,
Couple will pay. Couple will pay for their treatment. That is what is the affidavit, and that is what is for the insurance.
Because this all your insurance is not allowing that. Even when we ask them whether they will allow for the OHSS, it's not allowed.
That is why the affidavit says that if insurance will not give, I will give. That is what is the couple's affidavit, and that was required to be signed before the magistrate. Now they have relaxed it, and notary is allowed. So notarized affidavit is required, and if couple is not doing it, you can file a case against them that they are not following what they have signed for.
So even without an insurance, if there is an affidavit, we can go ahead with an egg donation.
Yes, if there is no insurance, you can go ahead, but we are telling to do both, because if couple is not giving, at least insurance company will give.
So the insurance company is not ready even for these things, they say.
But then you are taking the risk. Suppose couple is not giving, insurance is not there, then you have to treat her. You can't leave her. You have taken the oocyte donation. You safeguard yourself first. How can you be so sure that nothing will happen to your patient? If something will happen, and I am dealing with one case where donor had a problem in Hyderabad. So you have to, yes, and donor was in ICU. The insurance, it was between the main law and the rules.
So that's what the insurance says, that if it is related to the oocyte pickup, they won't cover up the insurance. That won't be covered.
That is why you take some insurance which covers. There are certain insurances which covers. At least give it a try. If suppose you have spent, you will have to spend any which way, because if donor has a problem, you have to take her out or you will let her die. You give one answer to me. You will take her out, right? You will do everything. Now you have two claims. Either you can push the couple because they have made an affidavit, and you can push the insurance company also to pay you. There are two payers. At least you have some chance to get money back. If you are not getting one of them, then you are losing your chance of getting the money back. So it is up to you how much risk you want to take.
So
I have just put in the chat for insurance. As per what is applicable for the oocyte donation, you can contact that particular person, and there are insurance companies who are covering from the within 24 hours with all the complications, etc., outlined in the policy. So you can contact her if you want to pass this information to your other members. You can contact her, and she can. There are a few insurance company who has done it.
Exactly. I'm telling you, there are insurance companies, and even if they find out some clause and they don't give, at least you have some avenue to file a case against them, right? Otherwise, you only will lose.
There are a lot of confusions regarding the ART bank and ART clinic in the same premises. So how do we go about it? Do we have in a different place, or in the same place with different directors, or the same directors?
So we have got multiple registrations of bank, surrogacy clinic, ART clinic, same premise, same name, same director, same everything. So the only thing that the law says, it has to be two separate entity. When it says entity, that means the reporting of the ART bank and the reporting of the ART clinic has to be separate. It doesn't talk about different premises, different company, or different proprietor director.
But what I suggest is, it is better to keep separate. Separate entity can be created by separate physical boundaries and separate director or separate administrator. Because what will happen if some reporting is wrong from the bank, or some issues is with the bank, and if they want to seal the bank, your clinic will automatically get sealed if it is same premises and same everything. If you want to keep it separate, they will seal that room which you have labeled it as a bank. The only point is, you have to put all the instruments and equipments required for a bank in that room as well. You will require another microscope, you will require another centrifuge machine, you will require another table chair, you will require another computer. So that separate investment will be there, but you will have safety that even if one of them will be sealed, at least the other thing will be operational. If you keep it same, then you will have a problem.
So should we always enroll in a software? Is it mandatory, or what type of software they recommend? Or is it anything, can we even, though we have a manual one, should we always put it in software? That is important, sir. That is one among the law. All the details and documents and data.
So, no, sir, please go ahead.
Hard copy is must for any document, because there is no way you can take signatures in all these forms. So you must have hard copies. You have to put the data on online when they become operational. You will have to put some data, whatever they ask for. But at least at present, all the hard copies are required of all the forms and all.
Yeah. So what I have recommended to the government is that whatever national registry is being formed, they can keep the API details open for that particular national registry. So if you have a software, your IT person can use the APIs to integrate the data uploading, which can happen automatically. There are a few government websites which have this kind of capability. So I've requested them to, have this facility available. So people or IVF centers who are using a software should be automatically able to upload data onto the national registry.
So one thing I just want to ask you, it may be the question for the next persons or the next sessions. See, when they come for PCPNDT inspection, they were asking, they are seeing the scan, they are seeing all the forms, and they are seeing the birth certificate and seeing if it is a third baby. And if that turns to be a boy baby, they were very specifically asking for cross questioning and making a lot of issues. So it's not a problem of ours, because they come with a pregnancy sometimes, and it's not even a treated pregnancy sometimes. So what is your advice regarding this? They come and ask for the birth certificate and say it's a third baby, how it is a boy baby. That is how they are questioning us.
I have answered this thing in Nashik. What happened? One of our clients, they got notice. First of all, in Nashik, they started asking the centers to give male to female ratio of birth in their hospital every month.
Yeah.
So they were asking for that ratio. And once it was given, for all these months, it was more female. But once they had some, say, 50 males and 40 females. So they immediately served a notice. So how I replied to it, I said, there is a constitution of the India. It says that no person should be made to give any evidence against his own self. That is the first fundamental right of a person. I said, you cannot ask the data from us and serve us a notice. That is first thing. Second thing, smaller the data, the statistic, less accurate it is. Suppose in my society, suppose in Mumbai, every minute one person dies. But in my society, nobody has died in 10 years. That doesn't mean one person doesn't die in Mumbai, right? So if you just see today's data, there may be 4 male born today and 2 female only for today's. But if you see my 10 years data, there will be more number of females and less number of, or it may be 50-50. So you have to see the bigger data for proper estimate of actual work. So just from one incidence, if they are asking this, they are either not having proper sense, or you can reply it like this.
So I think, by the way, we are going a lot of ahead of the time. It's almost
last question to Dr. Hitesh. 21-year-old boy, fertility preservation, his sperms been frozen. 2 years later, the parents comes to saying that the boy is no more, and they want to transfer the sperms to his girlfriend. What do we go about it?
See, now when we freeze the oocyte, the sperm or oocyte or any gamete, there is form 10 that they have to fill. If the boy was minor at the time of freezing, there is form 11. And it is mentioned whom to give that particular thing. If he was not married, it can't be used, because he has given it for himself. It was not for donation. If he has donated and died, then anybody can use that, right? But if he has not donated it, his purpose was totally different for his own use. Now he is no more. So it can't be used.
Yes, sir.
I think we should thank our experts, wonderful and amazing Dr. Hitesh and Dr. Nidis. So it is a very, very, very enterprising sharing of the knowledge. And on behalf of Oxy and my secretary and my team and all my EC, we thank you immensely for this wonderful exchange of your knowledge, which is so much precious. And I look forward a lot of very important and interesting things from the recording, because many of them wanted this, and it will be really grateful. Komal, we want your words also.
Yes, I think it was absolutely a pleasure because so many questions answered in that very short time. They were also relevant questions, and I think Dr. Hitesh and Dr. Nitish has done a wonderful job. You know, there are so many small details keep coming in our mind when we see this patient, whether we are doing right or no, whether we are documenting right, whether this is allowed or no, and every time, it keeps us in a dilemma because sometimes we have patients with different issues. They have special needs at time, as we spoke about the last case about somebody expiring, and then how the gamete can be used and whose wish and wills, emotions come differently, but the law is a very different issue. So we really need to have that balance as a medical expert when we are dealing with such an important subject like ART. And it was a wonderful session. I really enjoyed the entire question answers. So many doubts even I had in my mind were really solved because patients keep asking us when we counsel them and other things. So I think it was a fantastic initiative by OGSSI, Dr. Jayarajani and Dr. Kundavi. You have done a fabulous job, actually, this discussion. And I think people will really love to hear on and on this discussion, because when we talk, more doubts come into our mind and we really want everything to be cleared. So we wishing you all the best. I think really excellent discussion. Thank you, Hitesh and Dr. Nitish and Dr. Bhakta, who is the co-chair. So thank you so much. I really enjoyed the session, and thank you for inviting me to be the part of this session of medical legal aspects in ART. Thank you so much.
Madam, can I make one request?
Yes, sir.
I'm asking all the viewers not to learn law from WhatsApp University.
Yes.
Do not read that. Read the book, which is available for 100 rupees. Anybody who is having 100 rupees can purchase that from Amazon. ART and Surrogacy Law. Please go read it. More you read it, more you will understand. Read it once at least. Don't try to learn from hearsay or from WhatsApp University. That is my only request.
WhatsApp, Quora, and other people read from anywhere and they come and teach us, and it becomes very difficult.
Do not do that. Don't learn it from hearsay. Don't learn it from WhatsApp.
Thank you, sir. Thank you for that special. Really, that's a very important fact that we should keep in mind, and that gives a lot of insight. Thank you for sharing all your knowledge and expertise and experience with authority. Thank you, Dr. Nitish, and thank you, Dr. Nitish, sir, and also Komal and Dr. Rajesh Bhatt. Thank you for sharing this session so nicely, and thank you for being with us. Thank you, sir.
Thank you very much, madam.
Thank you, ma'am.
So much.
Thank you, and Dr. Hitesh. In spite of your busy schedule, you being with us. Thank you.
Thank you so much. And just before I go, I want your support from all you OGSSI members. I request your, it's a humble request from my side to support me in the upcoming election, that is the Vice President elections from the West Zone. And I would really be honored by your support and your encouragement. Thank you so much.
Thank you, Komal. Thank you. So we are moving on to the next session. I have the great pleasure and honor to introduce the chairpersons of the second session. Neha, can I have the CV of Madam Dr. Banita Sahe? So Madam is can I have her CV, please? So it's a great pleasure to introduce Madam Dr. Banita Sahe from Jamshedpur. She's a renowned and experienced gynecologist and a fertility specialist from Jamshedpur. She had a great experience of more than 22 years and has been associated with the best hospitals in Jamshedpur. And she's a dedicated, compassionate doctor who handles very many challenging cases with the latest cutting edge technology. And she offers a very great scientific advice to all the problems of the patient and also maintains the highest professional and ethical values. It is a great honor for us to have you, madam, to accept our invite to be the chairperson.
Thank you, madam. Am I audible?
Yeah, ma'am. Yeah, ma'am. So I'll
Okay.
introduce the next chairperson also, ma'am. I have the great pleasure and honor to introduce the uh, chairperson for this session, Dr. Victor Watsa. Can I have Sir's CV? He is the managing director and gynecologist from Dimapur, from Nagaland. Nagaland. He is one of the renowned OBGYN doctors in that area. He has a countless locals in have placed immense trust in this practitioner, and he's a very busy practitioner. I heard so. It's nice to have you, sir, for this webinar. And over to the chairpersons to introduce the speakers.
Thank you so much, Dr. Jairani, Madam. It's my prestigious webinar, which is organized by the OBG Society of the South India. And to becoming a chairing the session of this webinar, it's a really privilege for me. But we're going to discuss about the medical legal issue in obs and gynae. It's a really commendable job you people have done. You have taken ART rules and OBGYN medical legal issue. So, to coming to the session, we are going to introduce our moderator, Dr. Vidya Lakshmi Shishadri. She is the senior consultant and in the Sundaram Medical Foundation, Chennai, and president of OGSSI in 2021. She was past executive committee member and constitution committee member. And she also has a past chapter of secretary of Chennai IMS. So she was in Asia GCC Women's Health and Care Leader Award for the 2021. ICOG Valued Contribution Award in 2021. And she has a special interest in the high-risk obstetric and midlife health and medical law. Thank you for having you here, madam.
Thank
you. The next moderator is none other than our own Dr. Selvi Priya Sarvanam. She is going to have, can I have her CV, please? Selvi Priya Sarvanam is a gynecologist who graduated her MBBS degree from the Raja Mutya Medical College Hospital and Dr. MGR Medical University. And she also has achieved a diploma in radiation. And she has the experience of 20 years and specializes in the fetal medicine and infertility and gynecology. Currently, she is practicing in the Jaya Sekharan Hospital, Nagarkoli. A specialized treatment in infertility, obstetrics, artificial insemination, in vitro fertilization, and intracytoplasmic sperm injection. So coming to these two moderators, we will having the expert here also, Dr. Manish Machave and Dr. MC Patel, sir. Dr. MC Patel, sir, is nothing else encyclopedia of legal issues. He has worked a lot in this field in the FOXY and he has done a lot. He is a consultant obstetrician and gynecologist in medical legal counselor and organizing secretary of AICGU 17. He was organizing chairperson in MCon 2018. He was president Ahmedabad OBG Society in 2010 and 11 and national president Medicos organization in 16-18, president IM Ahmedabad in 7 and 8, and honorary surgeon Indian Red Cross Eye Bank, collected more than 1,000 eye pairs and organizing chairperson of Vivekanand Animo Conference in 2018. President Lion Clubs in Gatodia and Ahmedabad. So thank you, sir, for being with us. The next CV of Dr. Manish Machave. He is also as expert, he is with us. And both the expert, we will listen a lot, the obstetrician and gynecologist in endoscopic surgeon since last 20 years, and the cancer screening, hysteroscopy, hysterectomy, and all the thing, many special interests. Microwave endometrial ablation, fibroid removal, surgery, hysterectomy, polycystic syndrome, all the treatments are. He has got many awards in his credit, like gold medalist in Pune University, and membership Federation of Obs-Gynae Society of the India, and Indian Medical Association as a gynecologist endoscopist, Indian Society of the Assisted Reproduction, ISAR Pune, Association of Gynae and Endoscopic Surgeon. So now the stage is yours, madam. Please,
Yeah.
and sir, please start.
Thank you very much. Thank you very much for this opportunity, Oxy, Dr. Jairani and Dr. Kundivi. And we straight away go to the session on the discussion on medical legal issues in obstetrics and gynae as such. Of course, it's a very, very broad field, and already we have been informed that and obstetricians have the maximum share of getting sued for medical legal issues. And we have a very, I would say, I have seen Dr. Patel all the time explaining all the rules and regulations and trying to make us comfortable how we should practice, and at the same time, not really be very defensive, but at the same time, exercising all our knowledge and skill in a very safe and legal way. I'm really honored to have Dr. MC Patel in conversation, and as well as Dr. Manish. I think he said he would be going for an emergency cesarean, and if he joins us, we will be grateful to him to reply. Meanwhile, anyway, we will try to clarify many issues which keep happening every day in and day out in the clinical scenario, in our practice, whether we hail from a small place or a big place, whether it's in an institution or a small private nursing homes, we do face lots of problems. Welcome, Dr. MC Patel. Namaskar to you. Special regards to you. And all the time we have a problem of considering what do we take consent as. So let us start from the consent itself, because it is very, very difficult for us to get an appropriate consent. And so I would ask certain questions. Some are hypothetical, probably posed by many of the gynecologists and obstetricians around, and some what we can think of in a day-to-day scenario. So when we take a consent, and can a blanket consent be obtained? Because OG is one specialty where a patient walks in with high hopes, especially in obstetrics, and of course in elective scenarios in gynecology. And then something else we come across, a patient comes for a safe delivery, something else we get into, and then we have to intervene. So can we take a blanket consent from the patient when we are facing these patients? Patel, sir.
So anything related to consent. So before we discuss about consent, let us see one very famous case which was happened in Supreme Court in 2008, Samira Kohli versus Dr. Prabha Manchanda. And during deciding this case, Supreme Court has come out with guideline, or what should be the ideal consent in Indian context. And in that consent, which are the criteria for any consent to be valid, one criteria was consent should be procedure or operation specific. So blanket consent has no legal value.
Yes.
So you should explain everything in detail to the patient and patient party, that is witnesses, that what is your management plan, and which are the probable complication, what is the success rate, and who can sign consent. Everything was discussed during that case of Samira Kohli versus Prabha Manchanda. So it is very clear, consent should be procedure specific, yes, or operation specific.
Sir, the question
no
comes
blanket
when,
consent.
yes, sir. We plan for a procedure, and on the table we face a difference equally. We
Yes.
come across, as you said in Samira Kohli case,
Yes, yes.
the plan was something different, but on the table they found a different eventuality, and they proceeded for the good of the patient. But later the doctor was sued. So would like to know
There,
what
there,
happens. Yes.
there are two situations. If it is dial emergency, and if it is immediate necessary to save life of patient, no consent is required. Because in court of law, first dictum is save life of patient. And it was also mentioned in famous case of Permanent Katara. In this very case, it was case of a roadside accident,
Yes.
and patient was brought to one hospital, and hospital simply refuses being this case of a roadside accident, and it becomes a medical legal case. And patient had to be brought from one hospital to another hospital. Patient was saved. Patient was admitted in one of the hospital. But social activist Permanent Katara had a public interest litigation in court of law to come up with guideline. So in that very case, Supreme Court was very clear in deciding the case and giving guideline that you first treat the patient and all the legal formalities afterwards. So if it is an dial emergency, you can proceed further. But again, burden of proof is on your shoulder to prove that it was dial emergency. So you should be in a position to prove. One more thing, at the time of taking consent, you may explain to the patient that many a times it may happen that unanticipated, unexpected situation may happen. And if we have to go beyond the scope of consent given, can we proceed further, or can we extend the scope of consent given? So if patient has given consent like that, that you can very well proceed beyond the scope of consent given. One thing. One more area. Patient may give consent like this, that if any unanticipated, unexpected situations happens, and you have to go beyond scope of consent given by me, you can discuss with Mr. or Mrs. So and so, who is waiting outside labor room or operation theater or so. And if they give consent, that it will be considered as good as consent given by me. So if patient is very clear in his mind, in her mind, before giving consent, that proxy consent can be taken into consideration, or doctor may proceed further accordingly in this type of situation, then there is no issue and you can proceed further accordingly.
Sir, is there a special consideration when we have to, we know when the procedure is going to lead to either infertility or end of her reproductive life, then do we face the same consequence, or is it something different?
So many times at the time of cesarean section, we may consider that next pregnancy could be dangerous one for her.
For
But it
example,
is not
ruptured uterus. Yes.
ruptured uterus is a different story. If it is repairable, fine, you can repair. If it is not repairable, you have to go for obstetric hysterectomy also. Or in this type of situation, you have to take decision. But if at all uterus is repaired, and if you think that next pregnancy could be dangerous one, you cannot go for tubal sterilization operation if prior consent is not taken, because it is not immediate danger to life of patient. Patient is not going to be pregnant next day only. So you cannot go if prior consent is not taken for tubal sterilization or so. So whenever in this type of situation, one more situation, say for example, at the time of cesarean section myomectomy, many times we show big fibroid on anterior wall, and we think that let us remove that fibroid, it will be beneficial to the patient in future. But if prior consent is not taken, then you cannot remove that myoma also. Yes, of course, if it is in line of delivery in your incision, then you can very well remove that myoma without prior consent also. Same way, say for example, if you are going to go for any diagnostic hysteroscopy or laparoscopy, and if you find a case of PCOS and big ovaries, you cannot go for ovarian drilling unless prior consent is taken. So many times we think that it would be beneficial to the patient, it will be helpful to the patient, it would save pain, time in future, but it doesn't stand in court of law. In this
Yes,
type of argument, there's no legal immunity.
Can it be a common consent for both diagnostic as well as therapeutic purposes?
There can be common consent for diagnostic as well as operative or surgery and additional surgery. Say, for example, if you are going to go for hysterectomy and there is some ovarian mass. So if you can remove ovarian mass, leaving ovary, fine. If you have to remove ovary also many a times, then prior consent is very much needed in this type of situation.
Is it really necessary all the time to? Is it really necessary all the time to take spouse to consent whenever we are dealing with either sterilization or oophorectomies, bilateral oophorectomies? Is it necessary that the
So there are two views about this. In one of the cases, Supreme Court has a very important comment. When you are going to put full stop on reproductive capacity of couple, then spouse should be taken into consideration. He should be counseled, and his or her consent is also very much important. But there are circular in so many of the states that during time of tubal sterilization operation, consent of spouse is not required. So if there is a guideline on part of state government, and if you have followed that, then you could be out of problem if at all there is litigation in this type of situation, because there is no law as such. Whatever observation on part of Supreme Court was in that very particular case, of course it becomes, it can be taken as a precedent, but it is not law. So if there is a government circular, if there is a government guideline, and if consent of spouse is not required as per government guideline,
can you please
very well go.
mute yourself? Can everybody else mute themselves, please?
Yes, madam.
Sorry, sir. Yes, sir. Sir, one more thing is that suppose we take a case where patient has gone for delivery, her husband is not around, then she plans to go for tubal sterilization, postpartum sterilization.
Ligation.
So, yes, sir. Ligation, tubal ligation. Now, the husband is not around. He's somewhere else, say in Dubai or somewhere. So how do we take consent? Because now she wants to go ahead along with that, either during cesarean or immediate postpartum. So
is this decision pre-delivery or at the time of delivery or just after delivery?
Yes.
So if it is prior one, then even if husband is residing abroad, you can have a phone call or discussion on telephone also. You can explain everything. Or if you have time, then you can have consent from abroad also. He can give his consent by mail or by WhatsApp. It is possible. If it is an emergency, then if at all there is a time, then you can have a phone call. Otherwise, you can very well proceed accordingly if patient is willing to go for female sterilization operation. Because when patient is major, when patient is mentally sound, she can take decision of her own.
Sir, and suppose as we say, said the patient can tell ahead that there could be a proxy consent. Somebody can take decision on her behalf when she is under anesthesia. Then suppose she does not give that kind of a proxy consent, the permission for proxy consent, we come across sudden eventuality, then how do we justify taking some decisions?
So unless it is life-saving, you cannot do.
Yes.
If it is life-saving, if it is immediate necessary to save life of patient, and if you can prove it by your record, or say, for example, video recording or so, if you have gone with, then you can justify in court of law, because whatever you do in good faith of patient, it is always pardoned in court of law. But burden of proof is on our shoulder. So we have to prove it in court of law.
Sir, and when we are doing any gynecological surgeries and we come across some problem and suddenly we take the help of another department or another surgeon or somebody, then will it be called as a ghost surgeon, or do we have to mention that specifically? Of course, after the surgery, we are going to exhale, but does that be a value?
But in this type of situation also, at the time of taking consent, we should mention like this. If at all any need happens in some of the unexpected or unanticipated situation, we will involve surgeon or urologist. Say, for example, if it is a bowel injury, then we have to involve gastroenterosurgeon. If it is a bladder injury, or we have to involve urologist. So if we have mentioned prior in consent, then it becomes little easier one in court of law to face this type of situation.
And sir, if by chance, if 1 second, ma, and if, yeah, I'll give you, you want to add something?
Yeah.
Yeah, tell me.
No, because we are asking about concerns, and I want to know the role of video concerns in the obstetric practice.
Yes.
Always when you take a written consent, many of the times, even though the patients agree with all their consciousness and sign the papers, they easily twist saying that I was not aware of the clause, I was not told, I was not conscious, and all that. So, what is the role of video consent? What are the places where taking a video consent will really help obstetricians?
So one thing, whenever any person, not patient, any person, I mean, any person signs any document, it is presumed by law, whatever written above was acceptable to him or her. So it doesn't stand in court of law that it was consent was taken by force or by any other means. So it doesn't stand. As far as video consent is concerned, it is accepted evidence in court of law, but it is double-edged sword. Why? So if you miss any important point to explain, many a times it may be taken against you that this important point you didn't mention, you didn't explain. So even if you are going to go for video consent, then also written consent should be there on your table, and you will see that each and every point are taken in video consenting. But before you go with video consent, you should identify the patient with video that Mrs. So-and-so, aged so-and-so, residing at, and she should tell, yes, I am the same person. So identify person before starting video consent. And you explain everything in detail about your treatment plan or surgery or procedure you are going to go for. And then patient will say, and at the end, you will ask, whatever I have explained to you, are you agree with all this, or have you understood everything, or still you have any problem or any question or any query? So if at all she has any question, any query, and you answer, and if you have recorded everything, it becomes a good defense in your favor, and it is well accepted in court of law.
Sir, how long do we keep all these records, say for gynec cases, for consents, for medical terminations, and for
So if we go with law, so as far as MTP cases are concerned, we have to preserve for 5 years. As far as PCPNT cases are concerned, for 2 years. For ART cases, for 10 years. And then after, we have to transfer all those records to National Registry. As far as surrogacy part is concerned, for 25 years. As far as obstetric cases are concerned,
21.
At least 21. Because after attaining majority, she or he can sue within 2 years. Because as such, as far as CPA part is concerned, one should complain within 2 years of cause of actions happened. So in this case, we should preserve all the record at least for 21 years. In all other cases, at least for 5 years as per our MCI guidelines. And as far as income tax purpose are concerned, at least for 7 to 10 years.
Sir, there is one arena in our practice where, say, we have a placenta previa and we need blood transfusions, and we know there are people who believe in Jehovah's Witness. We do come across these people, and how do we protect ourselves against these? Because they totally refuse for blood transfusions.
So whenever patient doesn't follow your instruction, it becomes a contributory negligence on part of patient, and it becomes a good defense in your favor. But again, you will have to prove. So in this type of situation, role of negative consent is equally important. So patient will have to sign that I do not want or I do not give my consent. Many times it may happen patient or patient parties are not ready to give negative consent also. So in this type of situation, you can have a signature of any co-patient or any visitor of your hospital, and they will sign like this: whatever written above was explained to the patient and patient party before me, but they refuse to give consent. So if you have taken this type of negative consent by any other person, it becomes a good defense or a good document in your favor.
Sir, we have some patients, for example, who had some problems in their childhood and now they are pregnant. They don't want to reveal that condition to their in-laws or husband, say epileptic, heart disease and all those, and they come in pregnancy. Now, they keep on telling us, keep it secret. You need not give it on the documents where I'm going to share with my family. So you note down if you want, but never tell it to be this. So here in all these events, if there is a complication that happens related to the medical problem later, where do we stand and do we hold any responsibility?
So whatever information we get from patient during our practice, it is a privileged communication.
Yes, sir.
And as far as confidentiality is concerned, we have to observe all the confidentiality of all the information we get during our medical legal practice. When patient is major, when patient is mentally sound, patient can take decision of her own. If patient refuses to give this information to anybody, you cannot give any information to anybody. But there are some exceptions also. If patient is minor, she cannot take decision. In this situation, you have to explain everything to the guardian or relative. Or if there is some danger to public health, say for example, I would like to share one example. Uh, uh, a patient with her boyfriend, rather he was her fiance. There was engagement, and they had been to doctor for consultation to have some test, and doctor advised all the necessary tests, including HIV, and that boy came out to be HIV positive. So doctor declared that to that girl, and there was breakage of this engagement. Marriage was not done, it was engagement only. And case was filed by that boy that due to this disclosing this fact, there was broken off my engagement. Case was filed, but in this case, decision was in favor of doctor. When it is a case of public interest, public health issue, then you can reveal this type of information to concerned person.
And there is a negligence which is against the doctor for the surgery for some reason or foreign body, and all those things are not uncommon. And the vicarious responsibility falls on the medical institution as well. But how do we justify like what happened and what is the share that the hospital gets in for the commitment of a problem or a negligence by a particular specialist or a surgeon?
Any aggrieved person has right to complain against anybody, against doctor, again more than one doctors if you have involved more than one person during treatment, against staff, against hospital. So patient or patient party may sue against anybody. But in court of law, on part of prosecution, they will have to prove all the allegation they have made. So they can go with any allegation. As far as vicarious liability is concerned, if there is a principal or principal and agent, so if you can hire, if you can fire anybody, then he or she is vicariously, you are vicariously liable for them. It is very obvious. Say for example, there is fault on part of on your staff and something went wrong. So many times court will interpret that way, that amount of compensation that very staff cannot pay. So you will pay compensation on behalf of your staff because it becomes a vicarious liability. But it is applicable only in civil suit or compensation only. As far as criminal liability is concerned, there is no space for vicarious liability. Criminal liability goes very specifically and individuals only.
Sir, even for a simple procedure like a bimanual examination in the OPD, sometimes patients, we know it's an implied consent the moment they come and sit and we tell them, okay, we will be doing a vaginal examination. But sometimes after later something happens, patient is not comfortable. She goes to the effect of either assaulting the doctor or somewhere. So how do we circumvent this particular situation, sir?
So you rightly mentioned that it is implied consent. Once we explain everything to the patient and we say, go to the examination table, and if patient goes to examination table, it means she is ready to be examined. So as far as simple examination is concerned, no written consent is required. It is implied consent. One more thing, whenever you examine any patient, naturally one of your staff is present in examination room. If patient is minor, or if any patient is demanded for any relative to be present at the time of examination, and if relative is there, then it becomes little easier for you also to explain everything in presence of relative and before examination. And if at all she complains or allege anything, then opinion of your staff is also taken into consideration in court of law. That how you approach to the patient, what was the your approach to the patient for examination. There was nothing exaggeration. Nothing something which patient meant exaggeration. So that way you are pardoned in court of law. Nothing to worry.
So MTP is one big area, and we know the recent amendment in the MTP Act. But how much of this we can take in liberty? Like she just brings, this is my boyfriend or my this one, a young girl, and the consent-wise, who is responsible for giving consent?
What is the age of patient?
Sir, say 14 years, 15 years, a young unmarried girl.
If she is minor, then it becomes a case of POXO.
Yes,
so
sir.
you will have to inform police or CWC, that is Child Welfare Committee. And if patient has come alone, then you cannot entertain that patient as far as treatment is concerned. She can give consent for examination if she is more than 12 and less than 18. If she is minor but more than 12, she is considered matured minor in eye of law. So
Yes.
she can give consent for examination, but she cannot give consent for any procedure, say for MTP or any other thing. So in this situation, consent of guardian is very much required. If person with that patient, if whether he is her boyfriend or any other person, but if he is major and mentally sound, he can also give consent. So no consent of father, mother, or any close relative are concerned as far as POXO part is concerned. So in this type of situation, you can very well go with termination of pregnancy also. But there are some condition. Your center should be registered.
Yes, sir.
You should be qualified. Consent of guardian who is major and mentally sound should be taken in Form C. Opinion in Form 1 if pregnancy is less than 20 weeks. If more than 20, less than 24 weeks in certain condition, consent opinion of 2 registered medical practitioner. And if it is more than 24, opinion of medical board. So all these procedure you have to adapt. And one very important thing, product of conception, it is to be preserved in saline and it is to be handed over to the investigating officer, to the police also, to complete the investigation.
Selva Priya, are you there? Selvapriya, is she around?
But one
I am
more
there,
thing.
madam. I am there.
Yeah, please, please go ahead.
It was case of minor, but if she is major
Yes, sir.
and she has come up with her boyfriend,
Yes, sir.
need not to be her husband.
Yeah.
But when she is major, when she is mentally sound, she can take decision, she can give valid consent, and you can very well proceed with termination of pregnancy, because in this case, only and only consent of patient is sufficient to deal with the situation accordingly.
Yes. Yes, Selvapriya. You want
So,
to?
I am there, madam, but
Yeah.
I'm traveling. There's no
Oh.
light here.
Okay.
So,
Just a minute.
let me have some more comment about this. If patient is major and if patient is unmarried and she has come up to you for termination of pregnancy, say for example 8 weeks of pregnancy with her boyfriend, so in this type of situation, just I mentioned, you can very well proceed with termination of pregnancy. But in few of the cases it has happened, so I quote real happened cases. Sorry, after 6 months or so, many times police comes, that lady has filed a complaint against that person, that he had given me a promise of marriage. Now he is decline of her promise, his promise. So it becomes a case of rape. So police will come to you why you didn't inform police. So it becomes very difficult situation for us also to deal with the situation. So in this type of situation, whenever you are dealing with a case of married, unmarried patient and she is major, you should have a writing in her own handwriting that this is a result of consensual sex. I have no complaint against anybody. I do not want to inform police.
Sir, in a minor case, anyway, any intercourse is also considered as rape, right, sir?
No.
If
In minor, it becomes a case of POXO, that is sexual assault. So even if with her consent, because her consent is not valid when she is minor. So as far as minor is concerned, I just mentioned you have to inform police. But if she is major and if she is unmarried and if she is for termination of pregnancy, to be on safer side, we should have in her own writing like this 3 sentence. It is a result of consensual sex. I have no complaint against anybody. I do not want to inform police. Because at that point of time, she was very clear. She had no complaint against anybody. And doctor would not predict that she will have some problem with her boyfriend and she will complain in police. So better to inform police. Doctor cannot predict and doctor cannot inform police when she is major and when she is mentally sound.
Sir, sir, can I ask one question?
Yes.
What is the age of gestation we can do, even in the unmarried people? You have told about the 8 week. After that?
No. Irrespective of her marital status, you can terminate pregnancy in given situation as per MTP Act 1971. Up to 20 weeks of pregnancy, irrespective of marital status, irrespective of age even, if there is proper indication and if your hospital is recognized, you are qualified person with opinion of one registered medical practitioner, you can terminate pregnancy. More than 20 weeks, less than 24 weeks, with opinion of 2 registered medical practitioner, there are 7 conditions. You can terminate pregnancy in more than 20 weeks and less than 24 weeks of pregnancy. In case of minor, in case of mental retardation, in case of change of marital status during ongoing pregnancy. Say, for example, death of husband, judicial separation, divorce, and pregnancy has advanced more than 20 weeks and still it is less than 24 weeks. With opinion of 2 registered medical practitioner, one can terminate pregnancy. Physical disability. There is a list of physical disability under Indian Physical Disability Act. And if any of your patient falls in that category, you can terminate pregnancy more than 20 weeks, less than 24 weeks with opinion of 2 registered medical practitioners. Fetal congenital anomaly which are incompatible with life of fetus. You can terminate pregnancy up to 24 weeks of pregnancy with opinion of 2 registered medical practitioners. mental retardation. But in this situation, you will have to have an opinion from a psychiatrist. One more area on humanitarian ground. Say, for example, in era of COVID-19, there was notification on part of government that there should be minimum a visit of patient to the hospital. So in this type of situation, if pregnancy
Size increases.
then 24 weeks, one can terminate pregnancy with opinion of two registered medical practitioners. But in this type of situation, burden of proof is on your shoulder to prove that there was notification on part of government. So you should have a copy of notification on part of government in this type of situation.
And
So
I think
these are some conditions you can terminate pregnancy up to 24 weeks.
and
More than 24 weeks. If there is a congenital fetal anomaly which are incompatible with life of fetus with opinion of medical board in form D, that is prescribed form, you can terminate pregnancy at any given gestational age.
This medical board is at a civil surgeon's office, sir. Where is it?
Medical board is comprising of one gynecologist, one pediatrician, one sonologist, and government may appoint 2-3 more person from private sector also. So with this newer amendment, there should be a medical board in each and every district. So in few of the state, it is already formed. In few of the state, it is under process. I do not know about your state, but once it is already formed, that straightway one have to go to medical board for opinion, but only in case of congenital fetal anomaly, which are incompatible with life of fetus. There are one more provision in MTP Act, that is section 5. If it is immediate necessary to save life of patient, you can terminate pregnancy at any given gestational age and even at unregistered place also. No need to have place to be registered and no need to go for any formality. So you can terminate pregnancy at any given gestational age. But again, in this situation also, burden of proof is on your shoulder to prove that it was immediate necessary to save life of patient, and whatever you did, it was in good faith of patient to save life of patient.
And in early pregnancy, medication abortion, what we do, medical induced abortions, have the same rules and regulations to be followed like we do for the
It is the accepted method of termination of pregnancy. So all the rules and regulation will apply.
Yes. Sir, suppose there is a pregnant patient whom we have been seeing for 8-9 months, and then we are just out of station at that time, not available at the time of delivery. Somebody else sees, but there is a complication, either an intrauterine demise or some problem to the patient. Who is responsible? The person who is handling on that day, or also because it's our patient we have been seeing, or the vicarious hospital?
Just I mentioned prior also, patient may file complaints against anybody. Person who have handled the case, if you are, if it has happened in your hospital, then being a head of the institution, you may be also party. But in this type of situation, it could be joint responsibility or individual responsibility. So if it is proved in court of law that you were out of station, it was explained to the patient that you are not available from this period to this period, and Dr. So and so will be available to take care. And if patient has accepted his or her services, then he is a responsible person to take care. So in this type of situation, whenever you are going out of station for few days, you can have a board in your waiting room that I am not available from this date to this date, and care of patient will be taken by Dr. So and so. Patient is free to go anywhere else, or patient may take treatment from that locum doctor also. So it is accepted in court of law. Once there is some complication and case is filed, then if it is proved that it is sole on part of treating doctor, then court may give verdict against him or her only. But if you are also made a party as a head of the institution, under your roof it has happened, then court may pass verdict jointly or severally as far as compensation part is concerned.
Kundavi, are we finishing, or I can keep on asking sir and we can have any number of
Maybe
discussions?
another 5 minutes will wind up, Dr. Vijay, ma'am.
So I was just thinking whether.
So
if I'm
any
allowed to
question
ask
from
one question.
delegate part also we can
Yeah.
take. If
Sir,
it is in
I
chat
am
box.
having a question. Whether the recorded consent can be taken in the case of tube ligation. Sometimes the patient's husband says that you record the thing, I am agree for the tube ligation. So that recorded consent stand in the court or not?
Yes, it stand in court of law, but just I mentioned prior also, you should identify the person who is giving consent in recorded form. Because many times what happens, any person may be there on other part. We never know. So he will have to identify Mr. So-and-so, age, and where he is residing. And some other person should identify that he is the same person who is giving you a consent on video.
Sir, when we talk of obstetrics, sir, we send the patient for a particular scan and we tell them, okay, go, that center is best or something. And in that assurance, they go and some anomaly is missed. Later, they say, although the sonologist takes a major brunt, but then patient may say, you sent, that's why we went there. So we want to, they create that kind of an obstruction. Then how do we hold ourselves?
No, but we can tell in this type of situation, patient is always free to go anywhere as far as any investigation is concerned. If patient asks, can you suggest me good sonologist or good pathologist, then we can suggest 1, 2, 3, any number of doctors, and patient may go anywhere. But usually, if at all patient has selected sonologist, then also in report, he will write your name, set who referred the patient. So many times it is interpreted in court of law that you referred this patient to that very particular doctor. But in court of law, whenever you treat any patient, you treat as per your clinical examination and investigation. Say, for example, in this type of situation, report of sonography. So you are dependent to report. So this type of argument that you insisted me to go to particular sonologist doesn't stand in court of law, because it is very difficult to prove in court of law by patient also that we insisted or we deliberately sent to that fellow only.
Sir, regarding the histopathology, sir, sometimes when the histopathology report comes as in a center with an endometrial hyperplasia, and then when they operate and then it turns to be an adenocarcinoma, are we liable that we missed something? That's a question. See, sometimes
So,
we do a
in eye of law, it is very clear, whichever case you are dealing, whatever you do, you should be in a position to justify yourself in court of law. And how we can justify our standard textbook, standard journals, or some studies related to this type of cases. If it is a case of, say, for example, endometrial hyperplasia, so what prudent doctor would do in this type of situation? How will he or she investigate the case? And as per report of investigation, how he will deal with the situation accordingly. So we will have to justify ourselves in court of law, whatever we have done as per standard medical norms.
And also, if the junior or our postgraduate signs as a witness in the consent, yes,
consent can be taken by our assistant doctor also.
yes.
It need not to be taken by person who is going to operate. So any resident can take consent. Consent means whatever written above was explained to the patient by him who has signed the consent as a doctor. So it is very clear. So all the points should be taken well care at the time of counseling. And as far as role of witnesses are concerned, as such in eye of law, they are only witnesses that that very person had signed this consent paper before us. They have nothing to do with content of consent. Witness are only witness for signature of patient or per person who have signed the consent paper. So it is very clear.
And so, sir, nowadays sometimes patients just come inside. Now they have a mobile, and when we are trying to explain, they record that our communication, our counseling, whatever. How valid is that? And
so there are so many questions in court of law in this type of situation, because they will have to prove that conversation was between him and us only. So in court of law, again, it will be a long battle to go with. And we are safe in this type of situation. Many times court doesn't take into consideration this type of recording.
because sometimes they say, I don't understand much, so I will record it and show it to play it in at home. I will show this to this. So we allow that.
If you have allowed with prior consent, then it's another story. Because once you have allowed, then naturally there will be conversation. He will be asking, Madam, can I record this conversation, because I will have to give it to my family members for discussion. And if you have said yes, and it is recorded, then it becomes a good evidence that you had allowed, and this is recording of your conversation only.
We have a last question to you. In an ART, when we take a consent and they have a divorce, and then one of the party comes and asks you the complete documentation, are we justified in giving the document to the wife or the husband? How safe are we?
So if patient is major and mentally sound, I mentioned prior also, whatever information about her is with us is a property of patient, and we are custodian. So without permission of patient, we cannot disclose any information to anybody, including her husband. But if prior, at the time of counseling where her husband was with her and he has signed that very document, so it is very clear that he knows about that document. And if you give that document to her husband, it is not breach of confidentiality. But any other document which pertains to that very patient, and it is out of knowledge of patient, without permission of patient, you cannot give it to anybody, including her
if the court directs, or if the
yes, very different story. So if in this type of situation, if court asks, or any person who is authorized under law, say for example, any investigating officer may ask document from you. But in this situation, of course, you can ask from that investigating officer also in writing, please give me in a writing that you are investigating officer for this very case, and give me copy of complaint of that very patient. Then you can give a report to any other person. And whenever you submit this type of record, have acknowledgement that you have submitted to that very person, and identify that very person. Who is that person? Say, for example, any constable will come to you with letter of PSI to collect the record. That name of that constable, buckle number. Each and every constable are given buckle number. So buckle number, date and time when you gave all those record, and whenever you give record, there should be reference letter with reference to your request dated so and so. I am submitting this record to the person whom you have sent with following details. So it becomes good defense in your favor.
I think we should.
Sir, only one question about the antemortem cesarean. If the patient had a sudden collapse, sometimes we are forced to do perimortem for the baby's sake, that we have to take out the baby, whatever it is, alive or dead, we have to take. Should we take a consent from whom, or any witness should be taken?
But
What
in
is the-
peripartum cesarean section, we have almost no time to discuss
Yeah.
or to take consent. But very quickly, when we are preparing to go for perimortem cesarean, you may call any responsible person or relative inside, and you can explain very quickly that this has happened and this is the only way. If we do not do anything, then patient is almost gone. We are trying our level best, and let us hope for best. And you continue your perimortem cesarean section. And if everything goes fine, it's fine. And if at all something goes wrong, you will have to prove everything as per your record. Actually, what was the situation? What happened? How she collapsed? What did you do to save life? How you resuscitated well? Because it is a part of resuscitation only. Peripartum cesarean section also. Because whenever you take baby out very quickly, and at the same time, resuscitation is still continued by your assistant or other colleague. And if patient is saved, it is fine. And if at all you couldn't save, then your efforts to save life of patient are considered in court of law. Because in all the cases, ultimate result is not considered in court of law. But in this given situation, say for example, this patient had been to me, what I would have done. So that way court will consider. So in given situation, did you react or act way in which any prudent gynecologist would have done or reacted in the given situation? So if you can prove with all your documents in court of law, then it becomes a good defense in your favor.
I think the burden of proof is on the patient to prove our negligence, and it is burden of proof on us to prove our innocence.
Any negligence, any negligence, how long they can sue us, sir? So how many years later they can sue us? Is there any other specific period of time that we can say that, okay, I'm relieved of that problem?
As far as provision of CPA part is concerned, one can sue within 2 years.
Yes.
But if there is 2 years, not from treatment given, but from cause of action happened. Say, for example, you have done hysterectomy. You left mop inside. But after 10 years, if patient has a pain in abdomen, and if it is proved that that pain was due to mop only, and patient came to know that mop has left inside at that very juncture, I mean a point of time. So from that time, she can sue within 2 years. So 2 years since cause of action has happened. If there is delay, so say for example, more than 2 years have passed. If she can give valid reason for delay, then court may condone delay. So that is up to court. But usually within 2 years, patient should file complaint as far as compensation part is concerned. But as far as criminal case is concerned, there is no limit. Patient can sue at any time.
So we should keep our documents safe. Documentation is the only savior for us. So I think that is very important. Every event, everything, immediately or a little later also we should record. Thank you. I think Kundavi and Jairani,
Thank you so much,
sir, we have exhausted probably, sir.
Sir is continuously talking right from 7 o'clock. He's done the webinar and he's now here.
I finished
Amazing,
one
sir.
of my
Amazing
talk
is your
in parallel session.
energy and your knowledge and
Thank you.
Thank you so much, sir.
We are so much blessed to have you, sir.
Sir, you are
patient to
I had
reply.
a talk in parallel session about legal issues in obstetric injuries.
Oh, sir.
And after finishing that, I joined this webinar.
Sir, thank you so much. And in fact, sir is my inspiration. When I did my PG DMLE recently, I always, Dr. Patel was my inspiration.
I have already welcomed you in our club of medical legal experts.
Yes, sir. Yes, sir. Thank you so much, sir. And though late in life, but still I'm happy I did that. Thank you so much, sir. And really, you clarified lots of doubts, and I'm sure the entire audience would also be benefited greatly.
Thank you, sir, for replying each and every question so patiently.
Thank
after
you.
dinner time.
Thank you very
Every
much.
time we learn a lot from you. Every time some new queries you just clarify. Thank you so
Yes,
much.
sir. Thank you so much.
Welcome.
Sir.
And congratulate
Welcome.
this.
Thank you, sir.
Congratulate, Madam.
Yeah,
Jairani, you have done a very good
Thank you, ma'am.
webinar.
Thank you, ma'am. Thank you so much, ma'am. Thank you,
Good
ma'am.
night. Good night, Madam. Good night, sir.
Thank you, sir. Thank you, madam. Thank you, Vijayalakshmi ma'am, for
Thank
that
Good night,
wonderful
all.
getting all the expert things from sir. You have made it really interesting with all your questions, which is really
you.
important for all our clinical practice. Thank you, madam. Thank you, Selva, and madam, thank you so much for your presence. And
It's a wonderful,
on behalf of
wonderful.
Oxy, we extend our thanks to you, madam.
And Jaya, just to share,
Yes, sir.
in our continuous happy learning masterclass web series,
Yes, sir.
from September onwards, we are going with this type of series only. Delegates or the person opposite will ask and I will be answering. So
All
our
right.
series will be that way only.
Yeah, sir. We can keep it, sir. So we can even keep one session like that. It will be very good, sir.
So say for example, when we will be with the state of Tamil Nadu, so all the
We'll have
society.
TNFOG, sir. We will collaborate with TNFOG. We'll make all the societies to come.
That way also, and all the society we will go in parts. Say for example, 5 society at a time. So 5
Sure,
society president, secretary, or all the delegates from those very society will ask the question, and I will be answering.
Sure, sir. We'll do it, sir.
From September onwards, in our happy learning masterclass, we are going to that way.
Sure, sir. That will be really good, sir.
Very
All
good,
involved
sir.
with that.
Your happy learning masterclass is wonderful, sir. Very
So
systematic,
today
very,
was
very consistently you are doing, sir.
yes. Today was our 133rd episode.
Yes, sir. I know it.
Amazing, amazing.
Thank you very much.
Thank you, sir.
Thank you, sir. Thank you so much, sir. Thank you.
Okay.
Thank you.
So,
Recording
Just
stopped.
say a few words of thank you.
Thank you. Bye bye, Kundavi. Bye bye, Jairani. Bye bye. Thank you.
Yeah, thanks all the faculties who have joined us in this medical legal webinar, and thanks in spite of the busy schedule, and thank Emcure for the platform.